previous talk on conotruncal abnormality. So today we would move ahead and I'll discuss with you double outlet right ventricle. Last time I discussed tetralogy of Fallot's with you. Now in this again the same revising, conotruncus means abnormalities related with the conus and a common arterial trunk, that is the truncus, and they have many things in common: high genetic association, higher chance of extra cardiac defects. Four chamber is usually normal and likelihood of missing the abnormality is high because four chamber looks absolutely good or mildly abnormal. We are born with double outlet right ventricle. We have a truncus which is coming from the double out from the right ventricle in embryology in early stages, and that means embryologically we start with double outlet right ventricle, and then later on the aorta gets connected to the left ventricle. These are our cases of double outlet right ventricle, where the commonest being tetralogy of Fallot, and the very next common is a double outlet right ventricle. Conotruncal abnormalities, the cells which migrate from the neural crest to the cardiac tissue, and that's why the reason, because of this migration and extra cells, there is more chance of extra cardiac abnormalities as well as genetic associations. So conotruncal abnormalities constitutes about 10% of the total abnormalities, nearly normal four-chamber view. Diagnostic accuracy is not good, and there is a survival rate which is an issue. That's why, because of the extra cardiac abnormalities and genetic issues, a higher chance of terminations of pregnancy. Let me start with the differential diagnosis of a VSD with a single vessel overriding it. What are the differentials? You have a VSD and one vessel arising from that, overriding that. The first thing which should come to your mind is that, are there total two vessels coming from the ventricles? Then it could be TGA, that the chamber is one artery is overriding, another is coming from a different ventricle. It could be tetralogy of Fallot, it could be DORV. But in case you don't see the second vessel coming from one of the ventricles, then the differentials are different. Then the differential is, it could be a truncus and pulmonary artery arising from the truncus. It could be pulmonary atresia. It could be pulmonary atresia with vessels coming from the aorta called MEPCA. So now once you see one vessel arising from the overriding, it's overriding the ventricles, now you start searching from the second vessel. The second vessel, if it is pulmonary artery, if it is seen coming from one of the ventricles or a right ventricle, it should have a valve. So if he has a valve and coming from the ventricle, then that's the differential. In case you don't see pulmonary artery, you start searching it. Search it from the descending, from the ductus, whether there is a reversal, or search the collaterals in the descending aorta. So these are the common conotruncal abnormalities, and apart from this there is interruption of aortic arch, but obviously today which we are going to discuss is double outlet right ventricle. In this cartoon I am trying to explain the double outlet right ventricle physiology. You see this is aorta which is overriding the ventricle, and this override is more than 50%. So if override is more than 50% towards the right ventricle, it is double outlet right ventricle. If override is less than 50%, it is override of aorta. It could be tetralogy of Fallot. So that's how DORV is defined. One great artery, let's say pulmonary artery coming from right ventricle, and the second artery, which is aorta, is either wholly or predominantly coming from right ventricle. This becomes a double outlet right ventricle. In case of doubt that you're not sure about 50% of aortic override, whether it's 50, 40 or 60, then it's safe to mention it is a tetralogy like DORV. So this is a CT scan of CT angio of a congenital heart which is coming in a big way, It's from the apical side we are seeing. This is a tricuspid orifice, mitral orifice. This is interventricular septum, and you clearly see this aorta, which is more than 50% overriding towards the right ventricle. And same if the interventricular septum, you draw a line here, you see this is the aorta, more than 50% aorta is coming from the right ventricle. This makes it a double outlet right ventricle. Now, the double outlet right ventricle is one type of double outlet ventricles. Second is the double outlet left ventricle, extremely rare. I've just seen one case, and I haven't seen any case of double outlet both ventricle with both aorta and pulmonary artery. They actually override the ventricle septum. It's important because DORV is a kind of a syndrome, and both arteries coming from the right ventricle is just one component of the syndrome. To complete that syndrome, you have to know what other components are. First is the where is the VSD located? Is it below the aorta, subaortic? Is it committed to the pulmonary artery, subpulmonary? Or is it doubly committed? Is committed to both the ventricles? Or it's not committed to any ventricle. It's present in a remote location. It's not committed to either aorta or pulmonary artery. It's called a remote VSD. This has a very bad outcome I would share with you. Great artery relationship is the next, because great artery relationship actually decides which where the VSD is going to be, whether it's going to be subpulmonary or subaortic. Demalposed, we don't call it transposition because arteries are not transposed, because one artery, both arteries are coming from right ventricle, and it's not that aorta is coming from right ventricle and P is coming from the left ventricle, where we call it transposition of great arteries. So it's a malposed great arteries. That's why we define them as demalposed or a side by side relationship, or an L malposed great arteries, or could be a normally related great artery. Then Vanpra gave a very nice classification. Class 1 is a simple DORV. Class 2, if it is associated with common AV canal defect, it is implication which are very, very different, and DORV with heterotaxy syndromes. Both left and right DORV can happen. Then now putting all these components together, DORV can manifest in following ways. It can manifest as a VSD, it can manifest as a tetralogy of Fallot. It can manifest as a transposition of great arteries. So these are the various manifestations of double outlet right ventricle. So based on the VSD location and the great artery relationship, you can kind of classify double outlet right ventricle. The commonest being you have a subaortic VSD with side by side relationship of the great arteries, accounts for about half of the double outlet right ventricle. So commonest type of double outlet right ventricle is subaortic VSD and side by side relationship of great arteries. Okay, good idea to subscribe here, because whenever I'm going to post a new video, you obviously would be notified and you can look up that. I'm going to show you cases. Case 1 is aortic override, which is more than 50% from the right ventricle. See it again, aortic override, subaortic VSD, and it is more than 50% to the right ventricle. Here it is 50% or maybe less than 50% override of the great artery or aorta. So this could be either tetralogy of Fallot or DORV. So 50% override sometimes becomes very difficult and challenging to notice. And remember, once you're looking for double outlet, the overriding of a vessel or aorta, you must look at apical 5-chamber view or apical left ventricle outflow tract view. This is where it should be taken into account, 50% rule. Do not take into account when the heart is horizontal. When you are looking at the lateral 4-chamber view, that is not where you should say the override percentage, whether it's 50, 60 or 40. Okay, with this cartoon again I'll try to explain what is happening. This is the aorta VSD, and there is a more than 50% override. You move it slightly to the left side, and that's predominantly on the left ventricle, less than 50% override of the right ventricle. The percent override is percentage of override on the right ventricle. So it's 40% override on the right ventricle. So this becomes a tetralogy of Fallot rather than a DORV. Showing you cases, the VSD. Now VSD could be subpulmonary. Look at the pulmonary artery branching large, and this is overriding this ventricle septal defect more than 50% towards the right ventricle. So this is the pulmonary artery, and the VSD is subpulmonary because it's actually directly connecting with the pulmonary artery. How do I say? In this view, you see the VSD. I'm going to freeze it here and show you. Okay, let me go back and okay, yes. Now in this view, what do you see? You see a VSD, you see a pulmonary valve. You see a VSD pulmonary valve, it is subpulmonary. If you see a VSD and aorta, it is subaortic. And in this situation where you see a VSD, you see the pulmonary valve, you see the aortic valve, that means the VSD is committed to both aorta and pulmonary artery. It's called doubly committed ventricle septal defect. Remote. Remote VSD is when you see an inlet VSD, and when you see a VSD, you don't see any great arteries. Now you see the great arteries, pulmonary artery, aorta, and you don't see a VSD. That means VSD is not close to any of aortic or pulmonary valve. It's called a remote VSD. Now this is the case of an inlet VSD. And remember, if you see an inlet VSD or a common AV canal defect with a tetralogy of Fallot, almost sure that this is trisomy 21. And in case of DORV with a common AV canal defect, please rule out isomerism. It's very common. And in this case, you can always see an azygous vein, which is a proof that this is left atrial isomerism leading on to a plus a double outlet right ventricle. One can have a side-by-side relation. I showed a normal relation. I showed the demalposition of the great artery. This is side-by-side arterial relation. Pulmonary artery and aorta, pulmonary valve is thick, and the aorta is on the right side, aortic valve is on the right side, pulmonary valve side by side on the left side. They are not crossing each other, and then you see their pulmonary artery is small, which means that this is pulmonary stenosis. How do we know where the arterial relationship? One can go to volume rendering. This is a patient with the double inlet left ventricle. You see one inlet going to this ventricle, another inlet going to this ventricle, and this is Z plane. This is Z plane where you see tricuspid valve, mitral valve, and pulmonary artery and aorta, and this is tricuspid orifice, right side. Aorta is to the right. This is the right side, and this is anterior. So aorta is to the right and anterior of a small pulmonary artery. So this is what is demalposition of great arteries. Aorta to the right and anterior. These are the demographics that the DORV tetralogy of Fallot being the commonest type of DORV. Let's discuss about DORV with ventricle septal defect, which behaves like ventricle septal defect, meaning there is just a double outlet right ventricle, aorta more than 50% override of the ventricle septal defect, and there is no pulmonary stenosis. Okay, that's the case where you see aorta more than 50% override, and there is a mitral aortic in discontinuity. That's very, very important to rule it out from a simple VSD. Now you see the mitral valve, anterior mitral leaflet is attached here, okay, and the aortic valve should have been attaching here, but it make anterior mitral leaflet aortic valve continuity, but rather than that, there is a distance between the insertion of the mitral valve here to the origin of the aortic valve here. This gap is a conus. This causes discontinuity. There's some conus which has been interposed inside the mitral valve and the aortic valve, and this is a typical of a double outlet right ventricle, and that's how you see aorta arising predominantly from the right ventricle. But in this case, in a tetralogy of Fallot, you would have expected a pulmonary artery to be small. Pulmonary artery is not small. So that means this is not a tetralogy of Fallot with there is an override of a VSD, but the pulmonary artery is normal size. So this is DORV of a VSD type. So in the VSD type DORV, it's very, very simple. I'm going to show you by this cartoon. This is a DORV VSD type, and normally with DORV, the blood goes from RV into aorta and the pulmonary artery. And what do? We put a patch, okay, from the edge of the VSD to the other side of the aorta, so that the aorta is included into the left ventricle, and now the blood it flows from. So it behaves like a simple VSD, both surgically and even based on the prognosis. Tetralogy of Fallot, the commonest one. I'll show you three cases of this. This is the patient where had large VSD with both great arteries coming from the right ventricle. They were non-related to the non-diabetic. Why I want to specify non-diabetic is that these are the teratogens which can cause double outlet right ventricle, which is alcohol and retinoic acid. And if the patient is a asthmatic taking theophylline and adrenergic agonists or valproate for epilepsy. So these are high likelihood of developing double outlet right ventricle. Tetralogy of file double outlet right ventricle, the aorta, and you have a VSD which is connected with the aorta. You have a pulmonary artery which is coming from the right ventricle. There is a normal crossover, but you see the pulmonary artery is small. So you have aortic override more than 50%, which differentiates it from tetralogy of Fallot. So that makes it DORV, but there is a pulmonary stenosis. Now this becomes a DORV, which is something like tetralogy of Fallot, except that override is more than 50%. So what do we do here? I'm going to show you. Before that, let me show you another case. That's another case. This is the case of DORV. And let me go back, and in in tetralogy of Fallot, the surgery is done a similar manner like the surgery would have been done in a tetralogy of Fallot, and only difference is that you create a baffle to connect left ventricle with the aorta. Otherwise, the pulmonary artery surgery relieving pulmonary stenosis is almost the same. Let's go to another type, that is DTG, or a malposed great arteries, DTGA type. So this is the subpulmonary VSD. You see this is pulmonary artery, this is an aorta, this is coming from the right ventricle, arching up and forming a reverse boomerang sign, and this is a TGA type of DORV. The difference is that if I say if it is less than 50% override, then it becomes TGA, and if it is more than 50% override, it becomes DORV. So that is the rule of a 50% override. Okay, and then you see here the pulmonary artery is small. So this is pulmonary artery is small. So I'm going back to tetralogy of Fallot again. This is TOF-like physiology. Pulmonary artery is small, and you see some antegrade flow, retrograde flow in the ductus. So this is again TOF-like physiology, but the pulmonary artery stenosis is severe to the level that you have a flow reversal in the ductus arteriosus. So what does surgery done for DORV? TOF-like corrective surgery. In the corrective surgery, the same surgery as I told you in TOF, we go through the right atrium, we don't cut the right ventricle. The disadvantage of cutting the right ventricle and approaching this VSD, you produce arrhythmias, you produce RV dysfunction, and you close the patch from the right atrium and you widen the pulmonary artery by a patch. This is an ideal surgery. Many a times the pulmonary artery size is very small. Pulmonary annulus is very small. Okay, even if I put a patch, the pulmonary annulus is so small, it would remain like a severe pulmonary stenosis. In this situation, if this is the pulmonary valve sparing surgery, I am unable to spare the pulmonary valve. I would have to cut through the pulmonary valve. The pulmonary valve is sacrificed. So in this situation, the right ventricle is cut. Again, the right ventricle function would get affected. So this is less than ideal situation, but many a times we have to do it when the pulmonary artery is small. So whenever you are seeing a patient of DORV, the pulmonary artery is very small, you know that patient might require less than ideal surgery. And what is going to happen with less than ideal surgery? We have an absent pulmonary valve, there is a severe pulmonary regurgitation. Over a period of time, the right ventricle fails. So second or a first decade of life, this child might require another surgery of pulmonary valve replacement. So if you have a DORV and your pulmonary artery is very small, you are likely to counsel the parent that this child might require two surgeries, one immediately after birth and second would be when the child is about 10 or 20 years of age. Now, this is another patient of a four chamber view. You see, how do you see the axis? The axis is uh, about more than 90. So now this axis is a left axis. So this is a left axis shift. You see the four chamber view apart from the axis shift looks pretty normal, but when you move ahead, you see the aorta and there's an override of an aorta from RV, and then this is more than 50% override. You go ahead and you see very small pulmonary artery, which is about 30% size of an aorta. You see there is a pulmonary flow reversal. This pulmonary flow reversal is a critical component in this imaging. If you have a ductal reversal, this is child is might like have duct dependent circulation when the child is born, and these babies should be born in a tertiary care unit. You see this flow reversal in descending aorta. So in these patients, many a times the pulmonary arteries are too small. We need to make them grow. And how do we do it? We do it with a BT shunt. So in the counseling, if you have this patient with a very small pulmonary artery, you need to counsel the parents that child would require first a palliative surgery. That would be in first month or so, or depending upon the degree of cyanosis, where an artery, systemic artery is connected with the pulmonary artery so that the pulmonary arteries grow. So, and the main corrective surgery is done at 3 to 5 years. So, these children would require two surgeries. Going to show you a very interesting case. You see, this is DORV. The aorta is malposed, is side by side relation with the pulmonary artery. The pulmonary valve is thickened but doesn't seem to open. But this is the VSD. In the pulmonary artery, you see this is the forward flow, blue color. You see a red color flow, which is retrograde, and we get confused. If it had been a severe pulmonary stenosis, we would have expected an antegrade high velocity flow here, which is not existing. So that means there's something else. You know what it is? This pulmonary valve is not opening at all. This is pulmonary atresia, though there is a ductus which is filling the pulmonary artery. It is striking here the pulmonary valve and going back into the pulmonary artery. So now this, you now recognize the pulmonary valve is not opening. This is a sure ductal dependent circulation after birth, and child should be delivered in the tertiary care unit. So that's what it is. You see the pulmonary valve, that's the ductus. You see the ductus filling the pulmonary artery, striking here and again going, and there's no antegrade flow across the pulmonary valves, becoming a ductal dependent circulation. So now TGA type, which I showed you a case, and there's another case of TGA. This is this is a line drawn from the spine anteriorly, and you see the aorta is lying anterior and to the right of the pulmonary artery. Pulmonary valve is thickened and doming. There's a large ventricle septal defect, and the pulmonary stenosis, pulmonary artery, is smaller than the aorta. Not only that, this VSD is extending into inlet. How do I say this is inlet VSD? If you see a VSD, you see both AV valves, this is inlet VSD. If you see a VSD and you see semilunar valve, either mitral, either aortic or pulmonary, this is the outflow VSD. So large inlet VSD, TGA type with pulmonary stenosis. And what do we do? Surgery in TGA. Okay. Same way, initially RV is draining into aorta and pulmonary artery, and this is the pulmonary artery in TGA which is overriding the interventricular septum. Got it? What we do is that we close this VSD on the side of the pulmonary artery so that we connect pulmonary artery with left ventricle. Great. So what have we done now? We've tunneled the pulmonary artery to LV and we've converted DORV to TGA. Yes, now it's become a transposition of great arteries. LV to pulmonary artery and RV to aorta. Right? So now what do we do? We do the same what we do with the patients of TGA. We do an arterial switch operation. We switch the artery so that now right ventricle gets connected to the distal pulmonary arteries, left ventricle gets connected to the aorta. So in DORV TGA type, first we close the VSD, convert it into TGA, and then do an arterial switch operation. This is a single stage operation. I'm just telling you the steps of surgery. So if it's non-committed VSD, that's a problem because this is the VSD which I showed you is in the inlet and you don't see any sign of any pulmonary or aortic valve here. But when you see the pulmonary valve and the aorta, you don't see the VSD. That means the VSD is not committed to either of the arteries. Now, if the VSD is close to the arteries, either pulmonary or aorta, we can always connect that vessel with the VSD, okay, like converting into TGA or converting it as a normal. So no, it's neither here aortic so that we can tunnel to the aorta, it's nor here below the pulmonary artery so that we can tunnel it here. We have to create a large tunnel going through the right ventricle connecting to aorta. LV is, say, let's say it's the back side, the LV to this VSD, and then the tunnel into aorta. One is the tunnel might be small, it could produce stenosis. Two, it can obstruct tricuspid flow, it can obstruct pulmonary flow. That's not an ideal thing. So many a times we are left with no choice than to sacrifice all that, the right ventricle, and go to a single ventricle repair. Just a word about single ventricle repair before I conclude. It is in a DORV where you have a remote VSD, where you have a AV valve which is abnormal, or where one of the ventricles, right or left, is hypoplastic, then you can't have two ventricles supplying two systems, one pulmonary, one systemic. It's not possible because one ventricle is too small or not connectable. What do? We connect the one main ventricle or both the ventricles to the aorta. So single ventricle is supporting systemic circulation. What about pulmonary circulation? We connect the inferior vena cava through a baffle into the pulmonary artery. We connect the superior vena cava into the pulmonary artery. So both vena cava are connected to the pulmonary artery directly. Now the blood from systemic circulation goes back to the heart, not through right atrium, tricuspid valve, and right ventricle. It goes directly into the pulmonary arteries. This is just a pressure driven circulation. There is no ventricle pumping here, and there is no valve to check the backflow. So this is obviously not an ideal kind of situation children would have. So now to summarize, when you are looking at a DORV, what are the steps you should see? Look at the great artery relationship. Okay. Secondly, look at the place where the VSD is. Three is that you see whether what is the type of the DORV, and you see whether ventricle septal defect is it rootable or not. Thirdly, you see if there is any association like AV valve abnormality, the ventricular dysfunction, or one ventricle is small, or coronary artery abnormalities, which can affect the surgical impact. I hope you liked this very tough topic of DORV. DORV is a tough topic by itself. Try to simplify it as far as possible. Maybe next time I'll show you a case-based DORVs. I would show you small videos where I'll show you one case and what did we do in that case and how was the outcome, so that Gradually, over a period of time, you are able to understand the DORV thoroughly. Yes, do subscribe so that whenever I'm going to put the cases on DORV, you would be notified immediately. Bye till then.